Dr. LaDonna Schmidt, family doctor from Holton. I'm also president of the Kansas Medical Society. And as you all know, KMS is an advocacy organization, and we're fortunate to work with Kansas Hospital Association to help those in Kansas practice good medicine and keeping things in the physician's hands. We represent every specialty, and we're happy to be here today and really welcome everyone who is able to join us for the Physicians Leaders Forum. This is the second one in the group. We have a unique and special relationship with KHA, and we'd like to keep it that way so we can continue to provide high-quality care for our Kansas patients. If I'd like to just move on to our keynote speaker today, I'll introduce him. Mr. Sexton, our keynote speaker, has developed research instruments that have been used around the world. His current R01 grant from the National Institute of Health is a randomized clinical trial of resilience training. He has studied teamwork, safety, and resilience in high-risk environments such as commercial aviation cockpit, the operating room, and the intensive care units. With specializations in organizational assessment, teamwork, survey development, and quantitative methods, he spends his time teaching, mentoring, conducting research, and finding practical ways of getting busy physicians to do the right thing by making it the easy thing to do. It's my pleasure to introduce Brian Sexton.
Well, thank you for the introduction, and thank you all for having me today. I'm going to go through a fair bit of new information, new research that we've been involved with over the past 10 years. Starting in 2014, my lab got a $3 million grant from NIH to run a series of randomized controlled trials to show that we can improve well-being in healthcare workers, to show that we can cause to go down, and we can cause work-life balance to improve. And I'll be covering some surprising and hopefully interesting. Feels like we've got some hold music there. Just when I was getting interesting too. So we've got some surprising and hopefully interesting tidbits to share with you, and I'll be pointing you toward all the resources. These are all free resources that we have generated through this federal funding. There are three links I want to share with you today. One is for a tool that I'll share with you that you can share with others if you care. The second is to get an hour of CME credit. I'll give you the link for that at the end. That's also good if you're listening to the recording of this webinar today. And then the third one is for a shareable 3-minute video that gives you a concise summary of some of the topics that we'll be talking about today in case you want to share it with others. And the reason we do this is because we've learned some interesting things about what works and what doesn't work when it comes to fostering and promoting well-being. There are some old ideas about what is causing problems with burnout, and some of the kind of the things that we harp on are we complain about the electronic medical record. We actually did audits of user logs of our EMR at Duke University Health System, and we learned something kind of interesting. As much as there were boy-girl differences, like there are differences in males and females in terms of their burnout rates and their work-life balance rates, there are also different ways that our males and female physicians use the electronic medical record. It wasn't the electronic medical record itself that was predicting variation in burnout. It did predict some variation. It predicted about 1.3% of all the variation in burnout amongst our EMR users. But that's relative to 17.6% of the variance that is accounted for by the culture in which you work. Do you work in a place where nobody stops to eat lunch, or do you work in a place where everybody stops to eat lunch? Do you work in a place where nobody pees at work, or where everybody kind of pees at work? And that made a much bigger impact on predict burnout amongst our physicians, at least the ones that are using the electronic medical record. Now, we learned something interesting too. We just published this. It's actually in press, but not yet in print at the Journal of Perinatology. It was a randomized controlled trial of our bite-sized well-being intervention. We were actually able to show that we can cause well-being to improve relative to a waitlist control group. We showed that depression was significantly down in these healthcare professionals. We showed that burnout was significantly down. and stayed down 6 months later, and the work-life balance problems, so the issues with work-life balance were diminished, and they stayed diminished 6 months later. So we're very excited to be able to share with you some of the things that we learned along the way. We have a second RCT that we're publishing right now where the results actually last a year, and the intervention is even shorter. So we're trying to make this as bite-sized and as simple as possible. If you were running marathons and you were doing yoga and meditation before the world was on fire, then this is the time to lean into those skill sets. But if you weren't doing that and your gas tank is empty, we have to begin with things that are low barriers to entry, things where there's a high yield and a low cost to do these kinds of well-being activities. So let me, if I can, shape the way we think about and talk about well-being real quick. I want to give you a quick example. What if you were to walk into a room with a bunch of different tables, and you sit down at a table, and every table has a bowl full of chocolate chip cookies and a bowl full of radishes. Now, half of the tables in the room, you're told you can eat the cookies but not the radishes, and the other half of the tables in the room, you're told you can eat the radishes but not the cookies, and you have to sit there all day when there's lectures and all kinds of things happening. What do you think would happen by the end of the day? This is actually a test of available willpower of the people that are sitting there. Interestingly, what we know is that your willpower battery starts off at the beginning of the day as like a full in mobile phone kind of fully charged battery. But as you go through the day, you can use up more and more of your self-control and your willpower on things like this, making good decisions and good choices and showing good self-control. The folks at the bottom, they're using a lot more of their self-control because they can eat as many radishes as they want, but not any cookies. And through a whole bunch of different replications of this study, they've shown that when they're told, people don't eat the cookies when they're told not to eat the cookies. They'll pick them up and smell them, and the room smells of freshly baked cookies. And so it's very taunting, but it's a test of available self-control. Now, what do you think happens when we take people who have been told, go ahead and eat the cookie, versus people who are told, do not eat the cookie, whatever you do? If we give them another kind of test, in this case, it's a puzzle that has no true end. So it's how long do you persevere on this kind of puzzle that has no end? Those who were told they could eat the cookies, they were able to last 19 minutes into this puzzle, versus those who were told they could eat the radishes, but not the cookies, and they'd already used up some of that willpower. They only lasted about 8 minutes. And so how do you feel at the end of a long day at work? Do you feel at the end of a long day, do you feel like you have the willpower left over, the self-control left over to work on your goals? Do you feel like you have the willpower left over to work on your well-being? It is hard, and we use up so much of that in the service of others. And we need to understand sometimes we either need to eat the cookie or put the cookies away so we don't have to see them and use that available willpower. I'm a runner, and I know that one of the best ways to get me to run in the morning is to go to bed in my running outfit and leave my running shoes at the foot of the bed. That way, when I wake up in the morning, I'm like, oh my gosh, I'm already dressed for this. My shoes are right there. I might as well go on the run. So you can use some of this understanding of this diminishing willpower, or what is in psychology terms, it's called ego depletion. As you go through the course of your day, you're using up this available kind of resource. And what I want to do as we're going through talking about healthcare worker well-being is there are certain things that individuals can do and certain things that institutions or facilities or departments or divisions can do for well-being. And I'd like to pull a thread between those types of well-being activities that really work, that really are useful, because we know there are things that you can do for yourself that are quite sustainable. And we can look at you now, we can look at you 6 months from now and 12 months from now, and there's still an enduring benefit in randomized controlled trials. There's a lot of other stuff that sounds good, but it doesn't actually have enduring impacts on your well-being. And I want to show you how to evaluate for yourself the kinds of things that you're spending your time on and whether or not you think there's good evidence to support what is at the core of that as a well-being strategy. So why do we even need these institutional or individual resources in the first place? Well, let's start with the best predictor that we have for well-being, which, believe it or not, is work-life balance. And so we don't ask, are you work-life balance, because that basically predicts are you satisfied in your marriage or do you have good life satisfaction. Instead, we say, how often do you have certain kind of infractions into your work-life balance habits? So for example, how often in the past week did you skip a meal or eat a poorly balanced meal or not take any breaks or get home late from work or have difficulty sleeping or change plans because of work? That's a big one, by the way. Once you're guilty of this, a whole bunch of other things kind of go in the wrong direction. Or how many of you have felt frustrated by technology during one point in the past 7 days, or I get less than 5 hours of sleep during one of the nights in the past 7. These together give us a view into your current work-life balance, which is the best predictor that we have for what your well-being, what your burnout, what your emotional exhaustion is going to look like next year. This is the canary in the mine. It's the crystal ball that kind of tells us where your well-being is going. And this is really important. We just published well, actually, this is an article from BMJ where we showed across. This is my data from my institution. This is Duke University Health System. 396 different work settings at Duke. You can see on the left-hand side they've got terrible work-life balance. On the right-hand side they've got great work-life balance. So there is a lot of variation from one work setting to the next. But look at the title. It's called Work-Life Balance Behaviors Cluster in Work Settings. What does that mean? It means that if you work in a place where everybody takes breaks versus nobody takes breaks, eventually that impacts your behavior around taking breaks or your behavior around eating meals or self-care. So there's more of a social contagion to work-life balance behaviors and decisions than we thought. We certainly weren't looking for this, but once we found it, we couldn't not see it anymore. So where do we see the variation? Well, we see it by work setting, from one work setting to the next. We also see it by role, and the physicians have it the hardest when it comes to work-life balance. Over here on the left-hand side, you see our residents, our fellows, and our attendings. Basically, all of our docs have the worst work-life balance in our health system. We've seen this inside the Duke University Health System. We see this across the Michigan Hospital Association. We see this everywhere we look. It's just physicians don't have great work-life balance in general, and that's a kind of a precursor of things to come. What else do we see? Well, how long have you worked in your current specialty? And for people who've been working for less than 6 months in their current specialty, they've got pretty good work-life balance. But once you've been there for half a year, we kill your spirit and you begin to look like everybody else. If those who work days tend to have better work-life balance, and those who work 8-hour shifts tend to have better work-life balance. But what we've learned here is that there are sources of work-life balance that were unexpected. And the biggest one was that there's a social contagion effect. The work-life balance and the well-being of your colleagues is clearly associated with your work-life balance, whether you knew that or not. And we just published in JAMA Network Open here just a couple of, these are the author proofs because it's brand new. You can still find it on the website. Daniel Tofik and some of our colleagues at Stanford, we did this together with us at Duke, and we looked at personal and professional correlates of work-life balance amongst U.S. physicians. This was in a big cross-sectional sample of U.S. physicians. It was pretty involved, and in particular, the news wasn't great for our female physician colleagues. We actually surveyed over 4,000 U.S. physicians, and we looked at all the factors associated with work-life balance, things that predicted variation of work-life balance, and there were some specialties where there were huge variations between the boys and the girls when it came to work-life balance. The biggest disparities were within psychiatry, within emergency medicine, general pediatrics, and anesthesiology. That was where the boys and the girls were the most different. We also saw that hours worked per week was a big driver of problems with work-life integration. Age was interesting, but our female, who are in the red here, our female colleagues that are physicians, actually, it seems like at the end of their career, they get a lot smarter, which is decisions. When it comes to age of your youngest child, it starts off pretty much the same before there are children, but once there are kids in the family, our female physician colleagues do a lot worse with their work-life balance. They tend to spend more time on school-related activities, managing the household and doing all kinds of they spend more time in the electronic medical record. They also spend more time doing the emotional labor of kind of running a household. So we do see big gender differences in our work-life balance and in our burnout data. That's not a surprise. What was really surprising to us was that the electronic medical record played such a small role in this. So that's work-life balance. Let's take a look at burnout. So here's a study we did with 31 hospitals across the state of Michigan. It was 829 work settings, and we found the same thing that we found for work-life balance, but here we found it for burnout, an ICC of 0.26. Let me say what that means. 26% of your burnout as a practicing physician is predicted simply by who you work with. A quarter of your well-being is who's to your left and who's to your right on any given day. That's a lot. That's a quarter of your well-being is just who you work with, and your well-being impacts others, and their well-being impacts you. So this thing that we found for work-life balance, my goodness, we saw it in spades for burnout as well. So burnout's a team sport. We need to treat it as such. I love this anti-motivational poster. Burnout attitudes are contagious, and mine might kill you. That is exactly what the data are showing us. And some of you might be wondering, so how does this play out at the societal level? How does this play out in the operating room, in the ICU, in the ED? Some interesting ways it comes to fore. Did you see a couple of weeks ago in the news, the FAA, the Federal Aviation Administration, is warning of spikes in unruly, dangerous passenger behaviors? Isn't it interesting that in a typical year, the FAA gets 100 to 150 formal cases of these dangerous passenger behavior events? But in the first 3 months of 2021, when the planes were only a half to a third full, we already had 1,300 of these dangerous, disruptive passenger incidents. What do you think is going on at the societal level that leave everyone to kind of act a fool when they get on airplane? Why do you think that a lot of airplanes now? Well, we've been studying this idea of disruptive behaviors in healthcare amongst healthcare workers for a while, even before there was a global health crisis. And if you line up, this is a chart of 319 work settings over here on the right-hand side, the fourth quartile, they've got really high levels of burnout, high levels of what we call emotional exhaustion. Over here on the left-hand side in the green, they've got low levels of emotional exhaustion. Well, how do you think the disruptive behavior rates vary as a function of quartile here? When you got a lot of burnout, do you have more or less disruptive behaviors? Well, it's exactly what you would think. In fact, every kind of disruptive behavior we looked at is dramatically different when there's varying levels of emotional exhaustion present. So there's more bullying when there's more burnout. There's more publicly humiliating others, turning your back before a conversation is over, hanging up a phone before a conversation is over, making comments with sexual, racist, or ethnic slurs, and even showing physical aggression. Everything that we examined from disruptive behavior context was different in those work settings that had high rates versus low rates of emotional exhaustion. And it was a linear pattern. It was a linear trend. So the more disruptive behavior, there was more burnout, and vice versa. We did the same thing with looking at your intentions to hang around in your institution and your intentions to leave, right? To leave your organization and even leave the profession were higher when there's more burnout. And this was before a global health crisis. So people say, I'm more likely to, I would want to find a better job. I think about leaving this job. I have plans to leave this job within the next year, all higher, significantly so when there's more emotional exhaustion present. We did the exact same thing at Duke and looked at our turnover data and our burnout. And lo and behold, there were links between our burnout and our turnover. Lo and behold, there were also links between our burnout and our preventable harm. We got our preventable harm, our preventable medication-related SRS reports, our safety reporting system reports, were linked back to the extent to which there was emotional exhaustion in those work settings. What's the point I'm trying to make here is that there's a lot of reason that we should be focusing on how to limit and turn around these emotional exhaustion rates. And typical things that we do, I mean, no offense to Press Ganey, but their ability to predict important things like turnover and medication-related harm is like the NS there stands for not statistically significant. You have to look at things like work-life balance and things like emotional exhaustion to find the connection between what healthcare workers say about their well-being and the clinical and operational outcomes of the patients that they serve. So some of these employee engagement kind of companies that charge an arm and a leg for their pretty displays and their PowerPoint presentations, they're not doing a great job of actually predicting important, meaningful, clinically and operationally relevant information. But just like burnout is contagious, so is well-being. I got one more contagion fact to share with you. In 2019, new study just published, having a happy spouse is associated with a lower risk of mortality. Oh yes, that's right. It used to be happy wife, happy life. Now it's more like happy spouse, long live your house. That's right. For every 1 standard deviation increase in spousal happiness, there is a 13-point reduction in your risk of mortality. So we've found the social contagion for work-life balance. We've seen it for burnout. We've seen it for spousal happiness. You know, the well-being of ourselves and the well-being of others, it matters and it is linked. Let's start to kind of really understand now what happens in your brain so that you can be a better judge of some of these interventions. The psychology of burnout is such that what you're looking at, what you're focusing on, what you're thinking about is what determines your reality in a big way. What your focus determines your reality. What you're looking at really determines what you notice about the world in front of you. To give you a clinical example, if you show a CT scan of a lung like this to a room full of radiologists and you say, do you notice anything unusual about the scan? Why is it that 4 out of 5 radiologists don't see the gorilla in the upper right-hand quadrant there? Why is that? That gorilla is 23 times the size of the average cancer nodule that you're looking for in a scan like this when you're screening it. Why is it that 4 out of 5 radiologists don't see that? Well, it's because the gorilla is dark, and what you're looking for in scans like this are light or white colored nodules. So you're looking for the white, so your eyes skip over the dark. That explains in an interesting way what's happening in burnout. Lorenzo Bianchi's done some interesting work with the gaze tracking, where he puts helmets on people's heads and they can track people's pupils, and they have a screen inside the helmet where they can look at and see what people are looking at. And lo and behold, what they found is that when you flash positive images on that screen versus neutral images versus negative images, people who are depressed, just like people who are burned out, they will skip over the positive images and scenes. They'll skip over the neutral ones, but they focus like a laser beam on the negative ones. In fact, when you take the helmet off of their heads afterwards, after doing the gaze tracking, you can see what they were looking at. And it is true that the burned out people were skipping over. They weren't paying attention to the positive or the neutral scenes. In fact, what's interesting here is that those people who are burned out and depressed, they can recall with stunning accuracy the details in the images and scenes that were flashed in front of them that were negative, but they cannot recall or describe the positive or the neutral ones. What happens when you get burned out is you're directing so much of your attention span to the negative stuff. From an evolutionary perspective, why would that be? Why is it that why is it that when we're under stress, we'd be focusing on the negative? Well, if you are running for your life from a saber-toothed tiger and you're running and there is a threat behind you, what are you going to pay attention to in the world in front of you? Other things that might try to eat you or get in your way as you escape this threat that is behind you. The problem is, and that's great. Hey, that's a great way to keep your genes in the gene pool, because if you stop to appreciate a beautiful sunset or like a rainbow when you're being chased by a predator, you're not going to be passing on your children. That's just kind of how it works. However, we use the same mechanism when we're worrying about problems at work or problems at home or the prime lending rate or things like traffic. And that takes a toll because we no longer are able to see the good that's out there because we're so busy skipping over it so that we can focus on and obsess about the next bad thing. And what we've learned in our research is that the hallmark of well-being is actually this ability to notice the good and the bad side by side. The people who are truly resilient, people who are really able to bounce back after adversity, they're the ones that say, yes, yesterday was terrible, but today is better. They're able to kind of recalibrate their current mood to the current situation and see the good and the bad in the world at the same time. This is really important because when it comes to burnout, healthcare worker burnout has been associated with lower patient engagement, with higher infection rates, more medication errors, and higher standardized mortality ratios. I don't need to sell you on this. You know burnout is bad. But did you also know that of all the ways that we measure burnout, there's one that really kind of is better than all the others? We have emotional exhaustion, depersonalization, and personal sense of inefficacy. And of all three of these, the one that's definitely the best, in my opinion, when you look across research, thousands of research articles, the one that really predicts clinical and operational outcomes well is emotional exhaustion. This idea of I feel overwhelmed, drained, I can't meet the demands that are placed upon me. Emotional exhaustion translates well into different languages. It's used around the world. It was created by Christina Maslach in 1974. It's still the gold standard today for measuring burnout. That's what we use in our research studies. And we see, looking across clinically facing healthcare professionals, that between 40 and 45% of healthcare workers already meet the diagnostic criteria for burnout, just using this one of three pillars of burnout. So you can be burned out from any one of these three pillars, but just using emotional exhaustion, it's between 40 and 45%. That's a lot of burnout. Now, before the pandemic, between a third and half of healthcare workers already met the diagnostic criteria for burnout through using this emotional exhaustion. Now that number during the pandemic is closer to 2 out of 3. So it's technically worse than a coin toss right now as to whether burned out in healthcare. In fact, the impact of COVID has been such that it's like going live with 2.5 to 3 EMRs back to back in 1 year with no break in between. Why would you ever do that? No, you would never do that. There's just nothing else that we can compare to the impact that this has had on our well-being. Now, let me pause here for a second and say, I'm a proud father of 4 wonderful children, and my youngest child is Tatum. This is her right there. Now, don't judge. You might put your kids in a cage. If you had 4 kids, you don't know. But no, she likes to crawl into our crate with our miniature dachshund Willow. And Tatum recently says to me, Daddy, you're always talking about burnout. What is burnout, Dad? And so I said, well, honey, there's this diminished sense of personal accomplishment, and there's emotional exhaustion, and there's depersonalization. You're not really following me, are you, honey? And she says, nope. And I said, well, look, honey, burnout is basically what happens when it gets really hard to notice that something is funny or interesting or amazing. And she says, oh my gosh, Daddy, that is so boring. I'm not telling any of my friends that you work at Duke anymore. That is literally what my then 7-year-old said to me. But we took this definition back and we actually changed it. We published it several times since then. Burnout at its core is the impaired ability to experience positive emotion. I mean, it's harder to feel gratitude. It's harder to feel joy. It's harder to feel inspiration or awe or humor when you are burned out, when you are emotionally exhausted. There's 10 of these positive emotions, and they come to us courtesy of Barbara Fredrickson, who's been doing this research for 35 years. There's joy, gratitude, serenity or feeling at peace with the world, interest, hope, pride, amusement, inspiration, awe, and love. And all 10 of these have a tremendous amount of research behind them that we've been using in our interventions, that we've been using in our randomized controlled trials. I will simply suffice it to say, I dare you to feel like you're making a meaningful difference at work without experiencing one or more of these positives. You just can't do it. It's just the way that we're wired. So one of the big roles that positive emotions play in our well-being is it's how we feel a sense of purpose and meaning. And when it's harder and harder to access these positive emotions through the EMR or through the way we structured healthcare today, it's making it harder for you to bounce back and recover, which is interesting because Barb Fredrickson has shown that there's an undoing effect of positive emotions. It's actually through positive emotions that after an emotional upheaval, you begin to recover, you begin to feel better. You have a really bad day, somebody puts a hand on your shoulder and says, let me tell you about a time that something like that happened to me. You feel gratitude and then you feel better. It's how you kind of bounce back after adversity. So there's 2 big roles of positive emotions. 1, it's how we get meaning and purpose. And 2, it's how we recharge our batteries when they get low. And here is the $64,000 question. How on earth are you supposed to recharge your batteries and experience positive emotions when the world is undergoing a global health crisis? And so I'll share with you one example of an individual intervention, and then I'll share with you an example of an institutional intervention. And then I'm going to take you to a place where you can get all kinds of resources and goodies that are all paid for by our federal research grants. Now, I'll start with this one, 3 good things. What is 3 good things? When I first heard about it, I was like, you got to be kidding me. This sounds corny. And I didn't believe it. But the randomized controlled trial data was compelling. And so we dug into it a little bit more. And that was where it started to get kind of interesting. I was like, come on, I got real problems. I'm not going to do some silly, cheesy intervention to kind of help me with my well-being. But then we started kind of replicating what had been published in the literature, and we became pretty intrigued. In the first randomized controlled trial that was published in 2005 of this, they actually had folks every day for 1 week, just for 7 days, every day for 1 week before your head hits the pillow, before you go to sleep. You were supposed to reflect back on 3 things that went well that day. And then that's it. You just write it down on a piece of paper and then you go to bed. That was the original intervention. I know it sounds cheesy. I felt the same way. But you fast forward 6 months and the people who did this for 1 week, they are statistically significantly happier relative to placebo control. And they're statistically significantly less depressed. What is the effect size of that? It's actually pretty impressive. In fact, when you look at typical effect sizes for things like selective serotonin reuptake inhibitors, you're looking at in meta-analyses of randomized controlled trials, you're looking at an effect size of 0.3, 0.32 for depression. Here at the 6-month follow-up, after doing 3 good things for 7 days and then stopping half a year ago, you still got an effect size of 0.52. That is better than SSRIs like Prozac. That's impressive. So we dug a little deeper and said, well, what is the appropriate dose? So we're not using this on people who are severely depressive. We're going to use this on the doctors and nurses and pharmacists and therapists. And what does it look like when we kind of retool this for healthcare workers? What's the right dose? Do we do this for 7 days, or do we do this for 2 months, or do we 5 good things or 1 good thing? We monkeyed around with the dose of this for 7 years. And we finally published 45 good things, because it turns out the right dose for busy healthcare workers is 15 days. You do it for 15 days, you get a very enduring effect. How enduring? Well, your happiness goes up by 1 month after doing it for 15 days, and it stays up a year later. Your burnout is down by 1 month. It stays down a year later. Your problems with work-life balance are down by 1 month, and they stay down a year later. And depression is down by 1 month, and it stays down a year later. Can I just say, the difference between 3 good things and SSRIs is that if you stop taking SSRIs, the effect melts and you go right back to baseline. But if you stop doing 3 good things, we call it skills, not pills, because what you've done is you've strengthened your muscle to be able to see the good in an ocean of bad, so that ability to see the good gives you more purpose and meaning. It allows you to bounce back from adversity at work, and you get to squeeze more juice out of that fruit, and you're getting more out of it. That is why we call these bite-sized strategies, because it takes 1 to 2 minutes a night. And after 1 or 2 weeks, you have kind of a half year to a year's worth of kind of protection, which is pretty impressive, because you don't have to do this every day. You do this for 2 weeks, and then for the rest of the 50 weeks of the year, you can try other things or nothing, for your well-being. Well, we were really interested after this first study, and at what point does the effect really take hold? We did another study again with healthcare workers, and here we found that your burnout was already diminished by day 15. By day 15, by the last day of doing it, you're significantly less burned out. Not only that, your ability to thrive, really flourish at work, and also your ability to recover or bounce back from adversity was already better. These positively valenced well-being domains were already better by day 15, and they too stayed better a year later. So there's something about this. And I'll give you a nice quote from Barbara Fredrickson, who did all this positive emotion research for over 3 decades now. She says, the negative screams at you, but the positive only whispers. Well, what is it that you're supposed to do with that? Well, what I find so interesting is that it's hard to remember a good joke. But having grown up in Texas, if I hear the sound, I can conjure the sound of a rattlesnake sound, the Texas diamondback rattlesnake. I can hear that, and it just raises the hackles in the back of my head. Why is that I can conjure up something negative so easily? But to save my life, I couldn't tell you the funniest joke I've ever heard. Well, because there's no survival value in remembering something funny, whereas noticing and being able to identify the bad stuff is a great way to keep my genes in the gene pool. In fact, we're hardwired to remember the negative. That's what 3 good things is working against, so that we can actually strengthen our ability to see the good when it is there. So that's number 1. Number 2, we have enhanced recall of material that we review or reflect on during our last 2 wakeful hours. What's the best time to study for boards? Well, it's not when you wake up in the morning. It's actually before you go to bed, within 2 hours of sleep onset. That's when you're going to retain it more, retain it longer, and be able to integrate what you learned into the way you already understood the world. It's also the best time to do 3 good things, because if you're doing 3 good things, it works any time of the day, but in particular, the closer you do it to sleep onset, the more it has sleep aid qualities. So you'll fall asleep more quickly, you'll stay asleep longer, and your quality of sleep, so sleep quantity and quality, are improved. We also find that people who use 3 good things right before bedtime have an easier time falling back asleep if they have a lot of nighttime waking. So you can, if for nothing else, if your well-being is great, you can use 3 good things just to work on your sleep quality, which is one way. That's why we call it 3 good things in bed. Number 3, with practice by day 4 of doing 3 good things, you're already going to notice that it's getting easier to do this stuff. That it's not as hard as you thought it might be. So it's a kind of a zero entry pool. We call these bite-sized well-being strategies for a reason, because they are not very difficult to take on. So if you start it, we can do email or text. We'll email or text you a link. You click the link, it looks just like this. There's no sugar pill. There's no deception in our research. Good thing number 1. Good thing number 2. Good thing number 3. Good thing number 1. My 5-year-old swam across the pool at the YMCA without any floaties for the first time today. How did it make me feel? From that drop-down menu of those 10 positive emotions, I'll say pride. I was proud of my 5-year-old. Good thing number 2, watched as a glorious pink and orange sun set behind the rolling hills where leaves are changing colors. It was beautiful. How did it make me feel? Maybe I'll say awe and wonder. Good thing number 3, made my wife laugh so hard at dinner tonight, her eyes watered, and so did mine. How did it make me feel? Maybe I'll say amusement. Maybe I'll say love. You just did 3 good things. Boom. It's that easy. It doesn't have to be professionally related or work related. It doesn't have to be personal. You can choose how you want to use it. It does not make a difference what you make your 3 good things about. Some people, as you can see, write words like haircut. Some people write paragraphs. Some people write just phrases. It's whatever makes sense for you. You can put your own kind of spin on it. Some people, instead of doing it through us, you can just put up a butcher paper, a sheet of butcher paper and some Sharpies, and allow people to harvest their little uplifts as they go through their day. You can put a whiteboard on the back of your door and write down your good things at the beginning of the day, and encourage others to write them down as they walk by. You can start a group text with loved ones or family members. Here's an example of 3 good things at Duke Raleigh Hospital. They put up a bulletin board and those little 3M sticky tabs, and they simply write their good things on the sticky tabs and put them on the flowers as petals. Patients stop and do this. Family members stop to do this. Healthcare professionals stop to read through and then add to this. And then after 2 weeks, they take it down and put it up again 50 weeks later. You don't have to do this every day. 2 weeks is a full dose of 3 good things. To give you an example of what this looks like at Duke, 2,000 people had already enrolled. We did this survey of our healthcare professionals at the Duke University Health System compared to about 5,000 who had not yet done it. This is at Duke University Hospital. And when it comes to looking at our teamwork and our safety, our well-being and our work-life balance, every variable between the people who had just tried this 3 good things intervention versus those who had not tried it were significantly different. So it's related to not just disruptive behaviors, but well-being and teamwork and patient safety. There's lots of different reasons to try something like this out. What do people say when they try it? Well, 96% of our participants said that they would recommend it to a friend. 86% by day 15 say they've already encouraged others to try it. And 93% say they want to do it again next year. Can I just say, in the year 2021, if you can get 93% of any group of people to agree on anything, I'll call that a success. We live in a very divided country right now. So it's on demand. You can start anytime, email or text formats, and all you need is a mobile phone to do it. It is not an app. Can I just say this one more time because people confuse this? It is not an app. We'll ask you for your email address or your mobile number, you choose, and we will send you either an email or a text message for 15 days, and then we stop. That's how it works. So, well, here's what you do. You go to your mobile phone or your tablet or your computer, and you can just type in where you type in a web address, bit.ly/start, the number 3 GT, start 3 GT. That's all you have to do. And we'll immediately send you. There's the link right there again. We'll immediately send you. This is day 1 of day 3 of 15. We'll do it for 15 days and then we'll stop. Then there's a 1 month and a 6 month and a 12-month follow-up. And then we never contact you again. We're not allowed to per our IRB. So it is not an app. You don't have to download something to your phone and then delete it later. We just use your mobile number to send you these text messages to remind you to do it. This was something we learned from our internal medicine residents who said, if you don't remind me, I'm never going to do this. And so we actually moved away from email and we moved to text messages based on their feedback. The negative is like Velcro. It kind of sticks to you like staff. Just slides off. What 3 good things does is it makes the positive stickier so that you notice the good that is there. It's not pretend good. It's not like, oh, let's think about how working with a sociopath is really good for my character. Like, no, that's not good at all. What we're trying to do is notice the good that is there. You can do this by yourself. You can do this with your spouse. You can do this with your adult children. The only requirement to use the intervention is that you're 18 years old or older. The link is right there. You can share it in an email. You can share it in a text. You can share it in a flyer. It's pretty straightforward if that's something that you're interested in sharing with others. Now, the time it takes to enroll is 2 to 5 minutes to try it out. 1 to 2 minutes each evening, and after 2 weeks or 15 days, it's it. You're done. So this is what we call bite-sized well-being. It's not something that involves developing a new skill set. It's something very simple. I promised you a video. The link to the video is on YouTube, is bit.ly/3GT. I'll give you these links again at the end, 3GT demo. And that's just us showing you the science and how to use 3 good things and how to enroll if you're interested on YouTube. And I'll come back to that here again in a second. What I did want to share with you, though, is just this idea of how the individual interventions overlap conceptually with the successful institutional intervention. So let's shift a little bit our focus and let's take a look at something that we published in BMJ. It was a feature article in BMJ Quality and Safety a few years ago in 2018. And what we published there was that doing walk rounds, safety walk rounds, senior leader walk rounds was associated not just with better teamwork and better safety culture, but it was also associated with less burnout in the work in those work settings where people were doing it. Well, this caused us to pause and to reevaluate. Is there a way that we could be doing leader walk rounds that can actually be targeting the well-being of the staff that work in those units? So it's not just this inadvertent finding, but something that we can target. Well, traditional senior patient safety walk rounds was you walk into a busy unit and you say, hey, how are we going to kill the next patient around here? And what can we do to prevent it? And that was a wonderful way to provoke a patient safety and risk-related conversation in 1999. But in 2021, that's a great way to make a lot of healthcare professionals angry when they've got too many other demands on their plate right now. So instead, can you take some of what we talked about today? How do you kind of imbue this interaction with these positive emotions that we talked about? Well, it's very simple. Just a simple change in the way you ask that question would be, what are 3 things that are going well around here and 1 thing that could be better? We call this positive walk rounds. And positive walk rounds takes to the work setting level things that we were doing on individuals very well. Now, this is something that we just published in the Joint Commission Journal, but they just did a press. Excited that it's out there. It's brand new. You're one of the first webinar groups to see this. It's brand new publication. What we showed, we eat our own dog food at Duke. So across 500 work settings across the Duke University Health System, we asked the question, do senior leaders ask about what's going well around here? And the percent of people who said yes from the left to the right-hand side of the screen, you'll see that you can break it into quartiles. And what do you find? In the 4th quartile, we don't ask a lot of people about what's going well. In the 1st quartile, the green, we do ask about what's going well. And we see an interesting pattern here. When we look at all the different ways that well-being can interact with safety culture, employee engagement, and workforce well-being, every single domain was significant by positive rounding quartiles. So the more we ask people what's going well, the more they're able to kind of tackle quality improvement problems, so quality improvement projects. This is called improvement readiness. Or local leadership, whether it's a medical director or a nurse manager, is rated more highly in work settings where they're asked about what's going well. The teamwork climate, your ability to resolve conflicts and ask questions to clarify ambiguities and have good physician-nurse dynamics is better in those work settings where we ask about what's going well. The safety climate, would you feel safe being treated here as a patient? Are errors handled appropriately in your work setting? Well, the answer is yes, more often in places where we ask about what's going well. What about emotional exhaustion? You see the opposite pattern. So our emotional exhaustion levels are lower in those work settings where we ask about what's going well. Remember I told you about the social contagion? So how crispy are your colleagues? Their burnout is lower in those work settings where we ask about what's going well, and the work-life balance is better. So in every single variable that we measure, there's a significant difference. But wait, there's more. We also, in these Duke people who use as our guinea pigs for some of our research studies, sometimes we ask them these questions about pausing and reflecting. So around here, are you able to gain insights into what you do well? Are you able to pause and reflect on what we do well? And we call this kind of a climate of pausing and reflecting. And guess what happens to the impact of positive rounding if you statistically control for this pausing and reflecting? It goes to 0 or nearly 0 for Schwarzenegger rounds, for leadership walk rounds, for positive walk rounds, for peer support, for second victim support, for just culture, for every institutional training and institutional resource that we looked at. If you factor out this idea of pausing and reflecting, you lose all the benefits. The benefits just disappear. So I dare you, the next time you have an opportunity, to just insert into a meeting agenda a simple question. What's one good thing so far this week? So you've got lots of things to. You're on Zoom, or you're in person, or you're doing in a table discussion, or you're working aboard, or at a shift change. There's lots of things that we have to cover. But can you just very briefly, for the people who are present, go a quick round robin? What's one good thing so far this week? You'll be surprised. You'll be surprised what you learn about and from your colleagues when you use this technique. Not only that, we learned something really interesting from this big study that we did in Michigan. We actually measured leadership using the following items. Hey, leadership around here is available at predictable times. They provide provide frequent feedback about my performance, useful feedback about my performance, and they communicate their expectations. But in red here is the biggest predictor of leadership. The leadership in my work setting regularly makes time to provide positive feedback to me about how I'm doing. That one item is very potent in its linkage to burnout. How potent is this scale, this way of measuring leadership when it comes to burnout? Well, for every 10-point increase in leadership, At the work setting level, there is a almost threefold reduction in the odds of burnout for the folks that worked in that work setting. So there's a tight coupling between the way we evaluate our leaders and the way we feel in terms of our well-being. There's a lot that we've talked about here today. I'll just review a couple of the key points. Pausing and reflecting is the secret sauce that we identified for individual interventions like 3 Good Things. Do you pause and reflect at the end of the day about what went well? Institutional interventions like positive rounding. Do you pause and reflect about what went well? And even in effective leadership practices where you say, I'm going to pause and reflect with you about and give you some feedback about your performance, about what you're doing well. Those are some interesting common threads. What do we know in terms of the bite-sized well-being nuggets that we have covered here today? Some bite-sized strategies have some pretty enduring effects. Don't forget about the social contagion effect. Your well-being affects others. Their well-being affects you. There's the positive emotions, which are key to well-being, especially when it comes to sustainable quality improvement activities. If you want to be able to do QI for the next 20 years, we better make sure that we have got enough gas in the tank now. Because that emotional exhaustion is just a great indicator of your ability to do stuff, which is, if you want to have a really good understanding of what well-being is, it's your ability to do stuff. Well-being isn't happiness. It's your ability to deliver safe and reliable care to your patients. So we have talked about institutional and intervention and individual resources, and that pausing and reflecting is the key. If you want more information about this and what we do, you can follow us on Twitter. I put my Twitter account up there. We release all of our publications that are open source. We put PDFs of the actual publications. So if you're not a member of the journal or a member of a library, you can download all of our publications for free with just Google. We do that through Twitter. We also put videos, other resources, lots of goodies that we release through Twitter, or you can follow us on our website, hsq.dukehealth.org. We have a lot of enduring resources for pausing and reflecting, positive rounding, second victim support, psychologically safe leadership behaviors, and then leader walk-arounds are examples of some of these institutional resources. We have a whole litany of things that we do for individual resources, and this includes things like the one that's at the top here is Joy Reflections, which is how to cultivate joy. We have one for how to cultivate awe and wonder. We have one for gratitude. We have one for humor called 3 Funny Things. I wonder how that one works. We have one for work-life balance, which has been really popular. We have one for cultivating hope, we called the Looking Forward tool, which has been really powerful. It's been very popular as we're beginning to emerge from the pandemic. We have one for cultivating engagement called the Interest tool. We have one for mindfulness called 3 Good Minutes. One for perspective called the Door tool. It's one door closes, another opens. We help people walk through and guide them through some difficult transitions that they might be going through. We have one called the positive feedback tool. One of the biggest requests we've gotten positive feedback to others. We have a tool that's designed to help you get better at that. We have one for random acts of kindness. Hey, if you like the idea of 3 good things that are, you're just noticing good things, you want to supercharge that effect, do where you're doing 3 good things over the course of a day. And that's what we call our random acts of kindness tool, which is really fun. That's very, very popular. It's one of our tools that really has no, it's not like physicians like it more than nurses or nurses like it more than physicians. It's just really popular, the random acts of kindness tool. We have one called the self-compassion tool for cultivating self-compassion, which is really important when we've been challenged. We went for the serenity tool for cultivating a sense of routines and rituals and how to kind of maintain a sense of peace when there's a lot of things that are kind of going on simultaneously. We have one that's designed for sleep quantity and sleep quality called the sleep tool. We also have 3 good things here. There's a lot of different interventions and examples of things that you can do for your personal well-being. And before we transition, I hope you've got your questions ready. You've listened to me talk really fast for 50 minutes, so it's time to kind of get your questions out. I want to ask you what questions that you have, but I promised you 3 things: a link to a tool, a link to a continuing education certificate, and a link to the video. I'm going to leave these links up while we do the Q&A. The tool is bit.ly/start3gt. That's for 3 good things tool. If you want an hour of CME credit, you can get that at bit.ly/3THREEGT. And just as a quick reminder, the link to that video that we talked about that you're welcome to share with others is bit.ly/3GT demo. And with that, after talking very fast for 51 minutes, I'd love to give you guys a chance to ask questions, push back on anything that you've heard that you want more clarification on. And at this point, I'd be more than happy to either through the chat or through your questions, see what kind of comments and responses you have.
Well, Brian, I'll start things off with a question. I'm curious
Yeah.
if you have seen any research statistics about using these strategies specific to COVID. Have you honed in any of your research and really tried to dive into COVID specifically and how it's impacted folks?
Yeah, it's interesting. So I have two quick comments on that. The first is that during COVID, we really the thing that was missing for most of us was joy, and it wasn't as important during COVID, especially before the vaccines came out. It wasn't as important to make sure that you're cultivating hope. It turns out that right now, as we're emerging from the pandemic, this is the most important time to cultivate hope, because the landscape of returning to work and what that's going to look like and what the next 5 to 10 years in healthcare is going to look like is very uncertain. And the looking forward to, and I'll go back a couple of slides here. It's right here. On the right-hand side, bit.ly/FWD tool. That tool in particular has been wildly popular as soon as the vaccine started becoming more widespread. People really needed to work on their ability to kind of view tomorrow and next year and the year after next as being potentially even more positive than today. What is anxiety? What is depression? It's a broken way of looking at the future. And so we'd actually designed this tool to help with burnout. Well, and it does. It works well. We published it, and we've shown that it does reduce your burnout. What we weren't expecting was that the impact that this particular tool had on anxiety and depression was far stronger than the impact that it had on burnout. And so in particular, for people who are needing to kind of get a little bit more gas in their tank so that they can kind of weather a little bit more uncertainty, that looking forward tool is really important. So during a pandemic, during a prolonged period of uncertainty, you want to be able to cultivate joy. But right now, it's actually more important as we're exiting the pandemic to cultivate hope. Another thing that we've focused on, Jennifer, that is, what is this? We get this question from all corners. What is the simplest thing I can do for my well-being right now? And the answer to that is the gratitude tool. It's 10 minutes one time. And through our randomized controlled trials, we've actually shown that activity can result in we can cause your burnout to go down, your work-life balance to improve even 2 months later. So it's a one-time simple activity that it doesn't last for a year, but if you want to do something really simple and put a little gas back in your tank right now, the quickest and easiest, the simplest button you can push is called the GRAT tool, bit.ly/GRATTOOL. We get that question quite a bit. That's a great question though, Jennifer. Did that answer your question?
It did. Thank you.
Sure. I'll leave these links back up.
This Dr. Reddy, can you hear me?
I can hear you just fine. Thank you.
So does yoga help for burnout?
There have been a lot of studies that have been, there's a partnership between the Kripalu Center that is in the Berkshire Mountains of Massachusetts and Harvard Medical School, where they've looked at yoga and burnout. And the good news is, yes, yoga, having a regular practice of yoga is definitely linked to reductions in burnout. The problem that we encountered, to be perfectly honest, is that if you take people who are exhausted from a pandemic and say, hey, you should go learn how to put your ankle behind your neck, and it's going to be great, that just seems too overwhelming. It's too much of a life skill change for people who just don't have a lot of gas in their tank. So is it associated with reductions in burnout? Yes. It is also it's kind of like telling people who are overweight that they need to just do diet and exercise. Like, yeah, we know that. It's hard, and that's why we're not doing it. And so we actually shifted our focus away from meditation and yoga as the standard go-to well-being strategies, and we really focus on what we call bite-sized strategies. I'm not dissing yoga. If you have a regular yoga practice, that's fantastic. And people who have a yoga practice of even 15 to 20 minutes a day, they sleep better, they have better emotional regulation. It's impressive stuff. However, to get there is a pretty big lift for people who are really struggling with their well-being. That's a great question.
Thank you. It does answer. How about exercise, like walk on a treadmill for 30 minutes a day, something like that?
Yes, actually, moderate intensity exercise is associated with reductions in burnout and in depression. It's actually prescribed for people who are struggling with depression, and that's one of the reasons that some people, especially physicians that I know, that in residency they get addicted to running and they stay runners, kind of. There's a lot of emotional regulation benefit from doing that kind of moderate activity, intensity activity. That said, it is not my number one recommendation because it's a pretty high barrier to entry. If you come back from work and you're just exhausted and you think, well, now I got to go kind of run for half an hour on the treadmill versus can you take 1 or 2 minutes just to think about some good things that happened today? And here's the other thing too, to answer your question, we find that a lot of people who use the gratitude activity or 3 good things, it'll be a bridge to a more robust exercise regimen that they're interested in. So it's kind of like a gateway drug to running on the treadmill is doing some of these bite-sized activities, especially the gratitude tool. People who cultivate gratitude report that it's easier later on to do self-care, especially when it comes to sleep and exercise, which is kind of fun. Those are great questions.
Hey, Brian,
sir.
we've had some questions come in through chat. One
Sure.
wanting to know, you talk a lot about Duke, and understandably because that's your group and where you're at. But where else have you rolled this out? Do you have any idea how many organizations or where people are actually using these strategies?
Oh, yes. So we actually work with people like you, Jennifer. We work with state hospital associations. We've actually worked with 28 state hospital associations across the country to spread this. We have colleagues at Mayo Clinic, at Stanford, at Johns Hopkins, and at Harvard Medical School that we do these projects with. That's kind of like some of the academic centers of excellence when it comes to cultivating and doing a lot of evidence-based well-being. There's a lot of well-being stuff out there, but not all of it is published in good journals. Not all of it is done with like large sample sizes. So we actually, just to give you a sense, it's a great question. We enroll about 38,000 healthcare workers in our studies every year. We've been doing this for 10 years. And about 20, sometimes a little bit more than 20% of those enrollees are physicians. So more than any other group, we overrepresent physicians in our samples because a lot of physicians are curious and looking for these things, especially physician leaders who then take the interventions and then share them with other physicians in their practice. So they end up being great nodes, kind of well-being ambassadors to kind of share the goodies with others. Actually, I would say that most of our data comes from outside of Duke relative to from inside of Duke, but we have done some fun things in my health system where my colleagues were happy to act as our guinea pigs.
Okay, another question is, say I'm listening today and I'm a leader and I've been inspired by what you say. How am I going to get my other fellow physicians to buy in and start working on this together with me?
Great question. So you should just get the slides, because if you ask for the hour of continuing education credit, we will send you a copy of the slides, and you should just give the presentation yourself. Haha, I'm kidding. No, that's why we made the 3-minute video that's on your screen right now. So that if nothing else, can you pull up this 3-minute video on a tablet, walk up to your senior colleagues and listen, give me 3 minutes, I want to show you something. And that is a wonderful way. We have a video just like this for the gratitude tool as well. If you want to get it, it's on our website. It's a great way to say, here's some things that we can do right now that cost nothing. We don't have to work with a vendor. We don't have to have a budget. We just have to spend 1 or 2 minutes a day on this for a week or two, and then see what we think. And if we like it, we can spread it even further. So I'm trying to kind of give you the breadcrumbs, if you will, to see if you want to be that change agent, if you want to share the goodies with others, you're welcome to do that with these links that are on the screen right now.
Okay, so a couple of things, just some technical things. One, we are recording because I've had a couple of people say, hey, I was a few minutes late. I want to hear all of it. So we'll get you all a link to the recording. And then secondly, Brian, just to confirm that bit.ly, that portion you're going to put in your web browser. You're going to type that in your web browser, and that will take you to the place to sign up to receive the text or email notifications.
That's correct. That's correct. So the same place where you would put like CNN.com, you just type in bit.ly/start 3GT.
Okay, one last question that came in through chat, and then I'm going to turn things over to Dr. Dishman, is someone's interested in your thoughts about employee retention. It appears nationwide that there are a lot of people putting in resignations and moving on to new opportunities. I'm guessing if maybe they're wondering if some of this can help curb some of that folks leaving healthcare that we're seeing too.
We could give a whole webinar on what's going to happen to the workforce over the next kind of 5 years. I'm actually very concerned personally about what's going to happen when we get later into the summer and people are a year out from their worst moments during the pandemic last year. That's actually when a lot of symptoms of PTSD start to surface, and people who've been kind of holding it together with kind of duct tape, they begin to kind of fall apart at that point. We're seeing a lot of planned retirements. We're seeing a lot of planned departures, and that's going to put a tremendous burden on the people who hang around. Most of them are going to be much younger. They don't have the experience. They don't have the years under their belt. The people who are most vulnerable to burnout right now are people under 30. They're the most vulnerable. They are the most anxious, most depressed generation ever to come through the workforce. And there's a lot of reasons for that. It's the people who are in their 40s, 50s, and 60s that are the least vulnerable right now to burnout. And it's the ones in their 50s and 60s that are kind of eyeing the door right now. So we're going to see a pretty big departure of experience, which is going to create a whole new series of problems. All the more reason to be investing in simultaneously individual resources as well as institutional resources. The short answer to your question after that long answer is yes, these interventions can keep good people in difficult roles to weather the storm that's going to happen kind of in July, August, September of this year. We're going to declare a victory.
Well, I just want to check. Anybody else have any questions? Anybody want to just speak up and ask a question?
I have one more question, please, Jennifer.
Okay.
Dr. Sexton, I read before that 100 physicians die each year because of suicide. Is it true?
So yes, there's a pretty big problem with self-harm. In some specialties, it's a bigger problem than others. The short answer is yes. We're increasing our awareness of it. We're destigmatizing that more and more. I find that our younger anxiety, depression, they're also more open to talking about it, whereas the 40, 50, and 60-year-olds are a lot less likely, a lot less willing to talk about it or talk about their previous experiences with depressive episodes or really difficult dark moments during their time as a practicing clinician. So the short answer is yes, that's actually very true, and it's more true in some specialties than others.
Yeah, I heard that it is more with psychiatrists. I was surprised. Psychiatrist is the one that gives, treats the depression and all that, but they are the ones more committing suicide.
Psychiatry, yes, anesthesiology, dentists, and veterinarians are the groups that are pretty vulnerable. Yeah, and I'm in the Department of Psychiatry at Duke, and it's the largest. I think it's the largest department of psychiatry in the country. There's 500 of us. There's 275 psychiatrists and 225 psychologists, and it's a lot. It's a lot that they have to. They spend a lot of time in dark places with people who are going through some tough stuff. That's one of the contributing factors for them. It's a great comment.
Thank you, sir.
Well, Brian, I want to thank you for taking time to join us today. I'll note that you maybe aren't always practicing what you preach, because I know you're supposed to be on vacation, but you took time out of your break to be with us, which we're very appreciative of, but hopefully we're not going to diminish now your well-being because you took some time off to talk with us today. And I'd like to now turn things over to Dr. Kevin Dishman for some closing comments and to move us on to our next agenda item.
Thank you, Jennifer, and thanks again to Dr. Sexton for a wonderful presentation. A lot for us to digest, a lot for us to think about. I did want to take time to, again, speak to the deep value and pride and commitment that we have with the relationship between the Kansas Hospital Association and the Kansas Medical Society. The whole point to our clinical leadership is really to talk about that team of how do hospital leaders and physicians as hospital leaders create that meaningful relationship, that meaningful team that addresses issues such as the one we talked about today that are a challenge not only here in Kansas, but across the country. I did want to introduce Carolyn Westgate, who is going to speak to some of the resources that are available to our teams in Kansas. And she is director of the Kansas Medical Society's Professionals Health Program, and she will share more about what resources they have that are available to help. So, Carolyn?
Thank you. First of all, Dr. Sexton could not have done a better job in opening the door for us, because one of the key things that we use in our program is gratitude, humor, and hope are the three key things that we use often with the participants during very difficult times. We also utilize the Maslick that he talked about frequently, so that was excellent to hear that. Briefly, I want to fill you in on what the PHP does, but I also want to open the door and let you know additional things that we do that people don't anticipate. Yes, we work with the Board of Healing Arts, but that is not our primary role, believe it or not. We're designed to protect the health of Kansans and promote medical excellence among physicians with early identification, rehabilitation if there's concerns, and treatment of physicians and physician assistants for many types of mental, emotional disorders, substance abuse disorders, disruptive behaviors, other life circumstances that affect medical competency. Our goal is to assist the medical professional with a reported concern, helping their professional, personal life with the least amount of disruption to their medical practice. We want to be able to assure the public that the medical professional is safe to practice. We want to make sure that their rehabilitation is our primary focus at that time, and we're non-disciplinary in nature. Our referrals come from all of you. They come from clinics, attorneys, peers, other providers, hospitals, treatment facilities, family members, anonymous calls, other programs similar to ours across the nation, and self-reports. Reasons for referrals: mental, emotional disorders, suicidal ideation, grief, physical health, neurological issues, aging issues, cognitive delays, substance use disorders. People used to think that was our key thing, but believe it or not, probably disruptive behavior is on the top of our list right now, as well as some issues with COVID that I will discuss briefly. Burnout, boundary issues, stress-related issues from changes in practice, changes in the systemic nature of their world, inappropriate social media, unhealthy interpersonal relationships, and core competency issues. The COVID-19 has brought on a whole different dimension for us. Rather than go into what we do after the referral, I kind of want to focus on this right now because he brought up a great point about the PTSD and the hope. Throughout the pandemic, KMS PHP offered a 24-hour crisis hotline for those struggling. One of the key things that we kept hearing is this is demoralizing. We don't have anywhere to turn. I'm watching patients die left and right. I was trained to see this happen, but I don't know how to manage it. We do need to offer all the medical professionals hope right now. And we are preparing a way to continue that through a gracious fund of the CAMCO Foundation. We're going to be able to add to our staff to have 365-day-a-year, 24-hour coverage for a crisis hotline And we're also going to be implementing other things that can help with that. The pandemic has brought on a whole new set of concerns, but we can come out of it in a positive way if we all work together, such as this presentation today has been excellent. On a daily basis, we're also offering ongoing support without monitoring in many cases that don't require a mandatory report to the Board of Healing Arts. Some physicians email, text, call, they have personal issues of grief, of burnout, just looking again for hope. We received many calls and questions from CEOs, CMOs, COSs, HRs. Sometimes they have things specific to an individual. Sometimes it's anonymous. Sometimes it's questions about where can we send this person to a treatment facility. If any of you are considering sending someone to a treatment facility, please, I'm begging you, call us prior to doing that. We're encountering situations that physicians have been referred to facilities that are not approved by the Board of Healing Arts, or they're sent to a facility that is not qualified to address the issues at hand. We're also finding the wrong treatment facility can result in unnecessary monitoring, and it can result in an extended leave of practice, which is the one thing we don't want, and neither do you. You know, as we have physicians retiring early and leaving early, we need to retain people. The majority of cases we're involved with, and I cannot emphasize this enough, do not end up with board involvement. So the earlier you contact us, the earlier we can prevent board action and even monitoring. I'm not going to go into a lot of detail today about the PHP. If you're interested in more information, we offer a PHP 101 presentation, as well as a variety of other presentations. We do try to individualize our presentations to meet the needs of your facility. And you can contact us at 785-235-2383. Any questions?
So Carolyn, you mentioned a crisis hotline. How do folks find information on that?
Right now, it is listed on our KMS website. It is actually 785-231-1304. That's a direct line to my office. As we add staff, we are probably going to change that phone number, and we'll make that announcement when we get it. Right now, we're just transferring that line to our individual cell phones.
Okay, can you repeat that? 785-231.
1304.